It's pretty incredible how the human body adapts during pregnancy. Like for most people, there's this natural drop in blood pressure, right? And vascular resistance. It's this kind of beautiful, intricate dance of physiology.
Yeah, it really is amazing. But as you said, for about 7 to 8% of pregnancies, that dance takes an unexpected turn.
A serious turn, potentially.
Definitely. It leads to complications we really need to understand.
And that's exactly what we're diving into today on the deep dive. We're going to unpack three critical pregnancy-related conditions: hypertension, preeclampsia, and gestational diabetes. Our mission really is to understand what these are, who's most at risk, how they impact mom and baby, and crucially, how they're managed.
And we've got a good stack of expert sources to guide us through this.
We do, so let's get started. Okay, first up, hypertension and preeclampsia. So when a pregnant body develops hypertension, it's more than just a high number on the cuff, isn't it? What's actually happening inside?
That's the key question. It's not just high pressure. It's often a sign of something more systemic. We're talking about vasospasm.
Vasospasm.
Yeah, basically the narrowing of arteries, both the small ones and the large ones. And this narrowing increases resistance in the blood vessels.
This hinders blood flow.
Exactly. It hinders blood flow to really vital organs like liver, kidneys, brain, the uterus, and critically the placenta.
Right, the placenta, the baby's lifeline.
Precisely. So any disruption there is a major, major concern. It cuts off nutrients and oxygen.
Okay, that makes sense why it's so serious. So if that's the mechanism, who is most likely to experience this? Do the sources point to clear risk factors?
Oh, absolutely. There are some significant pre-existing factors that really stand out. Things like having antiphospholipid antibodies or SLE, that's systemic lupus erythematosus, an autoimmune condition.
Okay.
A history of preeclampsia is a big one. If you've had it before, your risk is much higher.
Right.
Also, pre-existing chronic hypertension or diabetes. Family history plays a role, too. If your mother or sister had preeclampsia, your risk goes up.
Interesting. What else?
Well, our sources also mention things like RT-assisted reproductive technologies, especially using donor eggs, also renal disease, carrying multiples.
Like twins or triplets.
Exactly. Having a high pre-pregnancy BMI, so 35 or more, being older, say 40 plus, or having a long gap between pregnancies, like over 10 years.
And it's worth noting, specifically in the New Zealand context, from our sources, certain genetic ancestries, African, Indian, Maori, and Pacific peoples, seem to have higher risks.
That's a really important point from the research. So it sounds like there's a spectrum here, not just one condition. How do doctors classify these different hypertensive issues?
Yeah, it's definitely a spectrum. We have distinct categories. First, there's chronic hypertension.
Okay, what's that?
That's diagnosed if you have high blood pressure, say 140 systolic or 90 diastolic, or both, before the 20th week of pregnancy, or if it continues more than 12 weeks after birth.
So basically high blood pressure you already had.
Pretty much, yeah. It's
Yeah.
pre-existing hypertension carrying into pregnancy. Then there's gestational hypertension.
And how's that different? This is new high blood pressure, again, 140 over 90 or higher. That starts after 20 weeks in someone who had normal pressure before. And the key thing is, it usually resolves within about 3 months postpartum, and crucially, it doesn't have those extra signs of organ problems that define preeclampsia.
Okay, but it could turn into preeclampsia.
Yes, it absolutely can progress, especially if it develops earlier, like before 30 weeks. So it needs careful watching.
Right. Which brings us to preeclampsia itself. This sounds like a definite step up in severity. What are the diagnostic criteria here, beyond just the blood pressure?
You're right, it's more serious. Preeclampsia is diagnosed when you have that new onset hypertension after 20 weeks, plus one or more new signs of trouble,
Trouble
like issues with other maternal organs or problems with the uteroplacental unit.
Okay, can you give some examples of those additional conditions?
Sure. A big one is proteinuria.
Protein in the urine.
Exactly. Too much protein, meaning the kidneys are getting kind of leaky, filtering improperly. Then there's renal insufficiency, so impaired kidney function beyond just the protein. Liver involvement is another. You might see elevated liver enzymes, maybe with pain in the upper right abdomen or epigastric area.
Right.
Neurological complications can happen too. Things like severe headaches that just won't quit, maybe with hyperreflexia.
Seeing spots.
Yeah, persistent visual disturbances like seeing spots or flashes scotomata. Or even more severe things like altered mental status, blindness, stroke, or the seizures of eclampsia itself.
Wow.
There can also be hematological complications, issues with the blood, like thrombocytopenia, which is a low platelet count, or hemolysis, the breakdown of red blood cells. And finally, and this is critical for the baby, uteroplacental dysfunction.
Meaning the placenta isn't working properly.
Exactly. This could show up as fetal growth restriction, the
Yeah.
baby isn't growing well, or even placental abruption.
Where the placenta detaches.
Yes, detaches from the uterine wall prematurely. That's really dangerous, can cause severe bleeding, even stillbirth.
This is really highlighting how crucial it is for listeners to recognize potential warning signs, maybe things that could otherwise be brushed off. What are those urgent red flags?
Absolutely, vital point. Everyone needs to know these.
Yeah.
Major red flags include sudden severe headaches that just don't go away, any visual changes, spots, flashes, blurriness,
Okay.
sudden, really noticeable swelling, especially in the hands, feet, or legs, like rings suddenly feel tight, or just extreme puffiness.
Yeah.
Also, upper abdominal pain, that liver area pain we mentioned, and persistent nausea or vomiting.
If someone experiences those.
Get medical help
Ew.
urgently. Don't wait.
Okay. So if preeclampsia gets worse, it can become severe. What tips it into that category?
Right, severe pre-eclampsia.
Yeah.
That involves even higher blood pressure. We're talking systolic 160 or more, or diastolic 110 or more.
Right.
Plus worsening organ dysfunction, like the platelet count dropping really low, below 100 times 10 to the 9 per liter,
Okay.
or further hits to liver or kidney function,
Uh,
or developing pulmonary edema.
Fluid in the lungs.
Yes, causing shortness of breath. That's an emergency. Requires inpatient hospital care immediately.
And then the most severe form you mentioned earlier, eclampsia.
Eclampsia.
Yeah.
That's the new onset of seizures in someone with preeclampsia. It's incredibly serious, life-threatening. It can happen before, during, or even after the birth.
Wow.
It's considered such a critical event that, for instance, in New Zealand, every single case has to be reported to the Ministry of Health. It basically signals that something went wrong in the monitoring or care process.
That really underscores the severity. So given how serious these conditions are, how are they treated? What's the management approach?
Well, the main goal is always to control the condition, manage the symptoms, and stop it from getting worse. For gestational hypertension, often antihypertensive beds are started. Common safe ones in pregnancy are methyldopa, labetalol, and ifedipine. And regular checks on blood pressure and for that proteinuria are absolutely crucial. For preeclampsia, treatment is usually inpatient. You'd use acute antihypertensives, things like IV labetalol, IV hydralazine, or high-dose nifedipine to get the blood pressure down quickly.
And for eclampsia or severe preeclampsia?
That's where magnesium sulfate comes in. It's often used for severe preeclampsia as well to prevent seizures.
How does that work?
It's pretty amazing, actually. It works in a few ways. It acts as a calcium antagonist, which helps relax the smooth muscle and blood vessels. It also helps limit fluid buildup in the brain, that vasogenic edema. And critically, it raises the seizure threshold, making seizures less likely. It's an anticonvulsant.
So it prevents seizures, but doesn't stop one that's already happening.
Generally, that's right. It's primarily for prevention of further seizures.
Okay, magnesium sulfate sounds really powerful, but I mean, there must be risks, right? Potential dangers.
Oh, absolutely. You're right to ask. Magnesium sulfate toxicity is a serious concern.
Okay, what are the signs?
Signs include things like loss of patellar reflexes, the knee-jerk reflex disappears,
Right.
also respiratory paralysis, heart block, circulatory collapse. It could even be fatal.
Right.
Because of these risks, it's only ever given in a hospital setting, very carefully monitored. And the antidote, calcium gluconate, is always kept ready, just in case.
Wow, okay. So if managing symptoms is one thing, what's the actual fix? The ultimate solution for preeclampsia and eclampsia?
The only definitive cure, really, is delivery of the baby in the placenta.
Right. Delivery.
Yeah. The timing and the method vaginal birth versus C-section depend heavily on how severe the condition is and how far along the pregnancy is. If the baby is still very premature, they might give the mother antenatal corticosteroids.
To help the baby's lungs mature.
Exactly. Ideally, they try to wait about 2 days after the steroids for them to have maximum effect before delivering, if it's safe to do so.
So we understand the need for delivery, but what are the potential impacts if things aren't managed well? Why is this such a huge issue for both mother and baby?
It's huge, because the fallout can be devastating for both. For the baby, that high blood pressure and vasospasm we talked about, it drastically cuts down the supply of food and oxygen through the placenta,
Leading to
fetal growth restriction, preterm birth, potentially stillbirth, especially if the placenta abrupts, or even infant death after birth.
And for the mother?
The complications can be just as severe. Things like stroke, seizure, that pulmonary edema, heart failure, even temporary blindness, liver bleeds, or severe postpartum hemorrhage after delivery.
These are serious, potentially lifelong consequences.
Absolutely.
Beyond treating these conditions once they arise, are there any proactive steps, things that can be done to prevent preeclampsia in high-risk individuals?
Yes, definitely. For women identified as being at high risk, there's a key preventative measure. It's recommended they start taking low-dose aspirin and also calcium supplements before 16 weeks gestation.
Aspirin and calcium.
Yeah. This simple combination has been shown in studies to significantly reduce the risk of developing preeclampsia and related problems like preterm birth. It's a great example of effective early intervention.
That's really valuable information. Okay, let's shift gears now. We've talked about blood pressure. Let's move to our second major condition, gestational diabetes, or GDM. Our sources suggest this is a growing issue, maybe linked to rising obesity rates, particularly noted in places like New Zealand. What exactly is GDM?
Right, GDM. It's fascinating because it's diabetes that arises specifically during pregnancy in women who didn't have diabetes before.
So it's pregnancy-induced.
Exactly.
Right.
And unlike type 1 or type 2, it typically goes away after the baby is born. But its prevalence is increasing, affecting maybe 8 to 9% of pregnancies each year.
Mm-hmm.
And as our sources noted for New Zealand, it's significantly higher in Maori, Pacific peoples, and Asian Indian populations compared to NZ Europeans.
And you mentioned a link earlier. GBM and hypertension can influence each other.
Yes, they can be risk factors for one another. It's a complex interplay between these conditions sometimes.
So who is most likely to develop GDM? What are the common risk factors?
Several factors pop up consistently. A family history of type 2 diabetes in a close relative, like a parent or sibling,
Okay.
having had GDM in a previous pregnancy, or having previously delivered a baby with a birth defect, or just a very large baby over 4 kilos, about 9 pounds.
Right, macrosomia.
Exactly. Being significantly overweight, so a high BMI before pregnancy. Age is also a factor, being over 30, which is now around the average age for a first-time mother in NZ. Other things include history of stillbirth or miscarriage, having had pregnancy-induced high blood pressure before.
There's that link again.
Yep. Or even things like frequent urinary tract infections or having polyhydramnios, too much amniotic fluid.
It's quite a list.
Yeah.
So we know who is more at risk, but why does it happen? What's going on physiologically inside the body during pregnancy that causes GDM?
This really comes down to the incredible hormonal shifts during pregnancy and how the body tries to cope. Your whole metabolism changes to meet the massive energy demands of the growing baby, the uterus, developing breast tissue.
A huge demand.
Huge. The liver also works harder, naturally leading to higher blood glucose levels in the mother. But here's the crucial part for GDM, the placenta. The placenta produces hormones, lots of them, that actually make the mother's body less sensitive to her own insulin. This is called insulin resistance.
So insulin doesn't work as well.
Exactly. Think of insulin as the key that lets sugar into your cells for energy. These placental hormones sort of block the keyhole. To overcome this, the mother's pancreas has to go into overdrive. It needs to produce about 3 times the normal amount of insulin to keep blood sugar levels stable.
3 times. Wow.
Yeah. If the pancreas just can't keep up with that massive extra demand, if it can't produce enough insulin to overcome the resistance,
Then blood sugar stays too high.
precisely. And that's when gestational diabetes develops.
Okay, so if this insulin resistance is happening internally, how is GDM usually found? You mentioned it often doesn't have obvious symptoms.
That's right. It's often silent, which is why screening is absolutely essential. Most women with GDM feel perfectly fine. So in places like New Zealand, routine screening is offered to everyone. Typically, there's an HbA1c test that gives an average blood sugar over a few months, offered before 20 weeks.
Okay.
If that's normal, then usually a 1-hour oral glucose challenge test is done between 20 and 24 weeks. You drink a sugary drink, and they check your blood sugar an hour later.
And if there are symptoms,
They'll usually be pretty vague, maybe increased thirst or feeling exceptionally tired. But those are so easily chalked up to just normal pregnancy stuff, right?
yeah, absolutely. Easy to miss.
Which really highlights why that screening is so important. We're hunting for something often invisible.
Okay. So let's say GDM isn't picked up or it's not well managed. What are the risks? You mentioned the baby potentially being very large macrosomia. That image of birthing a toddler really sticks. How does that affect the birth and the baby overall?
Yeah, untreated GDM carries significant risks for both. For the mother, there's a much higher chance of needing a C-section, often because the baby is so large. There's also that increased risk we keep mentioning of developing hypertension and pre-eclampsia, and more UTIs.
And for the baby,
Beyond being large.
being born very large, macrosomia is a big risk factor itself. It makes vaginal delivery harder, increases the chance of birth injuries like shoulder dislocation where the shoulder gets stuck.
Ouch.
Yeah. Then after birth, these babies can have dangerously low blood sugar levels, hypoglycemia, because they're used to getting so much sugar from mom via the placenta, and suddenly that supply is cut off.
Ah, okay.
They're also at higher risk for prolonged newborn jaundice, low calcium levels, and respiratory distress syndrome, which is serious breathing difficulty.
Okay, so clearly managing GDM is critical.
Lots.
Once it's diagnosed, what are the main strategies? It sounds like lifestyle plays a huge role.
Lifestyle is absolutely foundational. The core pillars are nutrition, managing weight gain appropriately, and keeping blood glucose levels tightly controlled. Let's break that down. What about diet?
So dietary advice is key. It's not about starving, but about smart choices. Aiming for at least 175 grams of carbohydrates per day, but spreading them out evenly across meals and snacks that helps avoid big blood sugar spikes.
Okay.
Reducing saturated fats, focusing on lean protein, and really busting that myth of eating for two.
Right. You don't need double the food.
No, only a small increase is needed. Weight gain targets are actually based on your pre-pregnancy BMI. For example, someone starting with a BMI over 30 might only be advised to gain 5 to 9 kilos total.
And physical activity.
Also crucial, the recommendation is usually at least 150 minutes of moderate intensity activity per week. Think like a brisk 30-minute walk most days.
How do you know if it's moderate?
A good guide is the talk test. You should be able to hold a conversation while you're doing it, but you should be able to sing easily.
Okay, that's helpful.
Activities that are easier on the joints and balance, like swimming, are great options. Important things to avoid: overexerting, exercising when it's really hot, and lying flat on your back in the second or third trimester, because that can compress blood vessels and, of course, stay hydrated.
Makes sense. What about tracking blood sugar?
Self-monitoring blood glucose is vital. Women are taught how to check their levels at home, usually fasting and then after meals. There are specific targets, for example. Fasting might need to be under 5.0 millimoles per liter, 1 hour after eating under 7.4, 2 hours under 6.7. These numbers guide the whole management plan.
And if diet and exercise aren't enough to hit those targets?
Then pharmacological therapy comes in, usually within a week or two if targets aren't met. Insulin injections are typically the first-line treatment. It's very effective and doesn't cross the placenta.
Are there other options?
Yes, metformin, an oral tablet, is another option. It has good safety data in pregnancy. It might lead to less weight gain for the mother and potentially lower risks of the baby being large or having low blood sugar. But women need to know that metformin does cross the placenta, unlike insulin.
Important distinction. And what about monitoring the baby?
Yes, fetal surveillance might be increased, especially if blood sugar control is difficult. Women are always advised to monitor fetal movements closely from about 28 weeks and report any decrease or change immediately.
And delivery. Does GDM affect delivery plans?
It can. If the baby is predicted to be very large, microsomic, then induction of labor might be offered, often between 38 and 40 weeks.
Why induce?
The aim is to reduce the risk of stillbirth, which can be slightly higher with poorly controlled GDM late in pregnancy, and also potentially reduce the chance of needing an emergency C-section during labor due to the baby size.
Okay, comprehensive management during pregnancy. What happens after the baby arrives? Does GDM just vanish?
It usually does resolve pretty quickly after birth, yes. But postpartum care is still absolutely critical because of the long-term implications.
Such as?
Well, first, breastfeeding is strongly encouraged. It's great for the baby, helps prevent low blood sugar right after birth, reduces their long-term risk of obesity and diabetes, and it's good for the mother too, reduces her risk of future diabetes and hypertension.
And the mother's risk of future diabetes is significant.
Hugely significant. Women who've had GDM have a 50 to 60% chance that's more than half of developing type 2 diabetes later in life.
Wow, 50 to 60%.
Yeah, it's a massive increase. That's why follow-up is non-negotiable. They need an HbA1c test again at 3 months postpartum to check if their blood sugar has returned to normal, and then they should be screened annually after that.
And does the baby have any increased risk long-term?
Yes, unfortunately. Being exposed to that high-sugar environment in the womb means the baby also has an increased risk of developing type 2 diabetes themselves later in life.
What an incredibly insightful deep dive. We've covered so much ground on hypertension, pre-eclampsia, and gestational diabetes. It's undeniably clear that while these conditions are serious, actually understanding the signs, the risks, the management, it's just incredibly powerful knowledge.
It really is. And that knowledge is most useful when it's, understood and actually applied. Recognizing those red flags we talked about, understanding how these conditions can be linked, It really empowers you, the listener, to be proactive, to seek timely care, and advocate for yourself or loved ones.
Absolutely.
And there's always more to learn, isn't there? Looking at it from multiple angles, like we've tried to do with our sources, just enriches that understanding.
It certainly does. So, maybe a final thought for you, our listener, to take away from all this. How does really digging into these intricate changes, the body's amazing adaptations during pregnancy, but also the potential for these specific challenges, how does that deepen your appreciation for just how finely balanced maternal and fetal health is, and maybe how critical that early detection and intervention really are? Thank you for joining us on this deep dive.